This day is not just about spreading the medical facts, but about building the empathy, encouraging early diagnosis, and promoting brain health across all stages of life. We are honored to have with us distinguished speakers, dedicated professionals, and passionate individuals who are making a real difference in this field. Your presence here, whether as a medical expert, caregiver, survivor, student, or concerned citizen, reflects a shared commitment to awareness and advocacy. Now, I would like to invite Dr. Rakesh Gupta, President and Director of Public Health, Strategic Institute for Public Health Education and Research. Before that, I would like to request everyone to turn on the cameras for group snapshot.
Should I take the snapshots or will you take?
Yes, sir.
I'll take the snapshots. You can just remove the slide, the PowerPoint. Then I'll take the snapshots. आप इसको शेयर बंद कर दो ना, शेयरिंग बंद कर दो आयुष. So I've taken the snapshots. You can start sharing. Yes, sir. Ayushi.
So this is the agenda for our today's event. And over to you, sir.
Okay, this. Yes, just take it forward. Next slide, please. Yeah. So this word, we are here for celebrating the World Brain Tumor Day. So we'll be creating awareness about this important disease. And it is observed on 8th of June every year, but we are celebrating a day earlier. So it was established by German Brain Tumor Association in 2000, and the purpose was to raise the global awareness about brain tumors, educate the public about symptoms, diagnosis, and treatment, support patients, survivors, and their families. And the significance is that brain tumors affect people of all the ages, including children and the elderly, and they often go undiagnosed due to lack of awareness. And the early detection can improve treatment outcomes. So that is why it is important. Next, please. Ayushi, you can change the slides, please. Ayushi? Ayushi, can you change the slide?
I think there's some issue. Just a minute.
Okay. So it has got a global reach. It is observed by the hospitals, the NGOs, the schools, and the health organizations worldwide. And events, they include awareness talks, fundraisers, walkathons. As gray ribbon represents the brain tumor awareness. And the theme for this year's Brain Tumor Day is brain health for all ages. And it emphasizes the importance of brain wellness at every stage of life. So we need to understand the brain tumors. And what is a brain tumor? It is an abnormal growth of cell. Dr. Manjul, and he's from PGI. But I'll be talking about it in brain. So it is an abnormal growth of cells in or around the brain, and it can be benign, non-cancerous tumor that originates in the brain, gliomas, meningiomas, medulloblastomas, astrocytomas, oligodendrogliomas, and the secondary or the metastatic tumors can be anywhere in the body and breast cancer. These are the secondary or the metastatic tumors. And the prognosis that depends upon the tumor type, size, and the location, and whether it is benign or the malignant. And it also depends upon the patient age and overall health and the treatment. The early ages, because the children, the development delays are there, infections are there. In the teens, the mental health issues are there, and the screen addiction is also there. In adults, stress, stroke, brain injuries can be there. And in the seniors, dementia, neurodegeneration, because it controls thinking, it controls memory, it controls emotions and physical coordination from early childhood to the old age. A healthy brain that supports learning, decision making, emotional well-being, and independence. And the key habits like regular exercise, healthy eating, social connection can protect the brain and enhance quality of the life. The factors affecting the brain health are genetics, lifestyle induced like diet, sleep, physical activity. Then mental stimulation is required. Environmental toxins are there, head trauma is logical, environmental, psychological, and healthcare factors. So maintaining a healthy lifestyle and managing the risk factors early can significantly protect and improve the brain health. Arjun. So Dr. Manjul Tripathi, he is professor additional at the PGI Chandigarh, and he's in charge of the radiosurgery, functional neurosurgery services at PGI, and he's in the charge of the Australasian Society of Neurological Surgeons, Neurological Society of India as well. So over to Dr. Manjul.
Thank you so much, sir. Thank you for this wonderful introduction. And
so, Dr. Manjul, we'll let you share your
yeah,
slide.
please.
Ayushi, आप कर सकते हो लाओ? अच्छा हो गया लाओ मेरे को हाँ लाओ हो गया.
I think I can share now. So. Okay. Is my slide visible to you?
Yeah. The slide is visible and it is in slideshow mode. Yeah.
Thank you so much, sir. So thank you, Dr. Rakesh, for this wonderful opportunity, and thank you everyone for joining us today. Because we are going to observe the Brain Tumor Day, it's a very important occasion today to raise the awareness about the condition that carries a significant implication not only just on the patient, but on the society, their caregivers, their families. And I'll take this opportunity to emphasize on the importance of the early detection, multidisciplinary treatment approaches, and the long-term survivorship. We have come to a time when actually, we have moved from just a life to a life with a quality. And that's why we are going to discuss this Brain Tumor Day today. Every year on June 8, the whole of the world comes together to celebrate this Brain Tumor Day. There is nothing to celebrate with the brain tumor. So we can reflect on the challenges when somebody is diagnosed with a brain tumor. Brain is one of the most complicated and the sophisticated organs of the body, and this is the only organ which couldn't be transplanted so far. You could transplant practically any other part of the body, like heart, lung, liver, but you couldn't transplant the brain so far. And the basic reason is that because your brain defines you. Your personality is defined by the brain. And we have been so far unlucky in going with it. So good afternoon, everyone, and I am sincerely thankful for this wonderful opportunity. I am speaking today on a beast which sits on your brain and which has an element of surprise, which have an element of making you frightened, the family frightened, and I'm going to take you to a journey on it. These are my disclaimers. As sir introduced, I am actually here in a hybrid capacity of a microneurosurgeon and gamma knife radiosurgeon. So I'm a sort of a neurosurgeon and a mixed variant of a radiation oncologist as well. And currently I'm holding many positions, but for this talk, I do not have any particular financial disclosures. And this is based on my experience of treating close to around 6,000 patients of different sorts of the brain tumors over the course of last 1.5 decades. When discussing the brain tumors, it is very important to understand the broader landscape of the cancer in India. And according to the Indian Council of Medical Research, there are around 5 to 10 per 10,000 population, which are suffering from some of the other sorts of the CNS tumors, which include the brain and the spine. And when we shift to the pediatric age group, this becomes further difficult because the brain tumor is the second most common solid tumor in the pediatric population, and the diagnosis in those cases becomes difficult because of their vague symptoms. Delays in diagnosis are common. And these tumors significantly impact not just only the survival, but the long-term neurocognitive outcome, quality of life, making the early detection and the multidisciplinary treatment absolutely necessary in those patients. This is actually the projection that we are going to face in the next 2020 to 2040. If you look at the epidemiological and the socioeconomic correlates, this number is going to be double in 2040 in 2020. And that is because of our longevity. There are more and more patients who are going into the 70s of their age. In those cases, the prognosis is also poor. And probably the mortality of those cases is also going to increase by close to around 35% in comparison to the general population. And that's why we need to be aware about the brain tumors so that we can diagnose them early, we can identify their symptoms when they are early in the course of their natural history, and their treatment becomes easy. And in this way, we would be able to identify the high risk groups like the elderly and the young children, in whom the CNS tumors are actually much more common. And that is the reason it is much more important to have raising brain tumor awareness among the caregivers, the people who are sitting on the PHCs, CSCs, and the general physicians who are actually the gatekeeper for these patients, to whom a general patient presents just with a headache or sometimes a seizure or some vague symptoms. There are a lot of myths about the brain tumors. All brain tumors are cancerous? No, this is not the case anymore. We know now with our pathology and immunohistochemistry and with the better natural history that most of these tumors are actually the benign entities, like the tumor of the pituitary, tumor of the nerve of the hearing. And these tumors are not going to take the life of the patient. There are certain tumors like the gliomas and metastasis, which are definitely cancerous, which have a chances of going to the other part of the body, but not most of them. Brain tumors are always rapidly fatal. That's again wrong, because these tumors are benign. So many times we can just observe, and it depends on at which particular stage of the patient's life we diagnose this tumor. So we can treat them, or we can observe them, or we can handle them with surgery. So that particular notion we need to depend with a custom tailored approach with a particular patient. The microphones, microwaves, or the mobile phones, are they causing the brain tumors? That is a common question which is being asked to me. Up to the knowledge which we have so far, there is no definite evidence that any such sort of a radiation causes the brain tumors. But we never know. I advise my patients that keep these devices away from you, especially when you're sleeping. Do not keep your phone near your head so that your head doesn't unnecessarily get sort of the radiation. If you remember the times of the Second World War, when the cigarette smoking was much more into practice, at that time people used to smoke, and they told that this smoking is not going to hurt you. But down the line, 3 or 4 decades, there are a lot of number of patients who are coming with the carcinoma of the lung, and the causative factor was smoking during the time of the Second World War. So probably in next 3 or 4 decades, we might be better aware of the etiology and the pathogenesis of the mobile phones and these radiations and the association with the brain tumors. So far, the evidence what we have, they do not find a direct causative effect. Headaches always means brain tumor? No, this is not particularly right. If a person is more than 65 years of age or a very young patient, like in the first decade of their life, if they have a new onset headache, that needs to be evaluated. But in the middle part of the age, this is usually the migraine, and you do not need to be really worrisome about it. There are days when surgery was actually so much disabling to the patient. Now our armamentarium is much better. We have intraoperative monitoring systems, intraoperative MRI, and with those, we go with the principle of do no harm. So we can take out the alien from your brain and maintain your personality, your quality of life. Brain tumors are hereditary. Yes, they are hereditary in certain conditions, and tumors are actually not hereditary. Once treated, brain tumors never come back. That's again a wrong notion. Depending on the pathology, you will have to decide whether this tumor may come back or not. Most of the benign conditions, they have a very long period after the surgery. Once removed completely, they wouldn't come back. But I personally do not claim anybody that I have cured the patient for the life, because the brain tumors, their pathology is still evolving. And in those cases, there is a chance that the tumor may come back, because there are certain subtypes of the genetic types of these tumors, which despite being benign, may have a tendency to come back. That's why a patient with a brain tumor needs to be under some watchful monitoring for the rest of their life. I claim that I can control tumors for a very long duration of time, or probably for their life, but I refrain myself, or everybody as a neuroscientist should refrain themselves from claiming that they have cured somebody for the life. We can cure certain disorders, but not most of the brain tumors, but we can control them, maintaining a good quality of life for a very long duration of time. It affects only elderly people, and that's again a notion which was popular among the earlier generations. Now, with the better identification, with the MRIs and the better radiology, we are encountering these most patients early in the stage of their natural disease, so that even before being symptomatic, those patients are diagnosed. I'll give you a common example. Like now, the youngsters come to me saying that I am able to hear better in 1 year in comparison to the other year. And the reason for that is that they are regularly using the mobile phones. Earlier, this tumor, which is affecting the nerve of the hearing, used to present when the patient started having debilitating symptoms like difficulty in walking or something like that. Now, with the sudden, simple difference in the hearing, they come to the doctor, they consult the doctor that I'm able to hear better in 1 year, and then we get an MRI and we identified that patient is suffering from a vestibular schwannoma or something like that. So the better radiology, better understanding, they have actually helped in early diagnosis of these brain tumors. What causes brain tumors? That's a question. People ask, why me? Why did it happen to me? And there are certain reasons for that may happen in that patient, but most of these brain tumors are sporadic. So you do not find any family history. Certain genetic mutations, certain patients with family history like neurofibromatosis, they have a higher chances of brain tumors. A word of caution is that try to avoid any sort of the radiation exposure until unless it's very necessary. A mere X-ray or a CT scan, they definitely expose you to the risk of a brain tumor. So try to avoid them as far as you can. Try to maintain a healthy mental and physical health with a good exercise regime. Give time to your brain to relax. Do not just remain on your mobile devices for most of these times, so that you get some time for your brain to relax also. There are certain immune system disorders which are rare, but they predispose your brain for certain brain tumors. The signs and symptoms of the brain tumors are actually very much dependent on the location in which the brain, in that the tumor happens. What is a tumor? Tumor is an abnormal collection of the cells in certain part of the brain. And the brain is unique in its way that the different lobes, different parts of the brain have different certain features, different certain functions to do. And if a particular tumor happens in one particular area, then you may have a mathematically correlated signs and symptoms in those areas. There are certain general symptoms like headache, but this headache is usually an early morning headache, usually associated with nausea or vomiting, and the patient gets some relief after the vomiting. If somebody comes that I have started getting this early morning headache when my sleep, I gets awakened from my sleep and then I feel nauseating. Once I vomit, I feel better. Then that sort of the headache is usually a brain tumor headache. Depending on the location, patient may through seizures. There might be some weakness in the limbs. There might be difficulty in the speech, vision, hearing, difficulty in maintaining the gait. Sometimes patients present with the psychiatric symptoms, and once we evaluate those patients, we find that the reason is something else. Reason is the tumor sitting over in the brain, and that's why the patient has started having some psychiatric symptoms, some depressive symptoms, or the patient has some mood changes. There are memory problems. Patients are not able to recall what they had in the morning in the breakfast. And then gradually we come to know when the family members complain that he is not the same person with whom we were living for so many years. So in those cases, these are the red flag signs, and you need to be really aware of those ones. The headache, which is usually a very common one with which the patient presents, can be evaluated with a common mnemonic called the SNOOP. SNOOP means neurological symptoms. When the patient is having headache, early morning headache, and then there is certain symptoms like he's finding some abnormal shakiness in some part of the body. Sometimes in particular part of the life, age of the life, you get that sort of a headache like in pregnancy, because certain tumors have a tendency to grow during the pregnancy, like the meningiomas. Once patient presents with these specific symptoms and complaints, then you need to be really wary of these complaints, and you should evaluate those patients. The rule of thumb in neurosurgery and in brain tumor is that location is everything. The brain, if you see here, there are certain parts of the brain and there are some layers of curtains over the brain. And these curtains are dura mater, pia mater, adductoid mater, and then you get the bone, and then there is a periosteum, and there is the skin over here. A tumor may arise from practically any part here. And depending on the part from where it is taking an origin and the surrounding neighborhood which it is compressing, you may have different signs and symptoms of those patients. If you classify these tumors, as Dr. Gupta just told, the tumors might be arising right from the brain, which is called the intraaxial tumors. there might be tumors which might be a secondary tumor from somewhere else. Patient is suffering from a carcinoma of breast, and the tumor tissue has migrated from breast to the brain. Those tumors are called metastasis, and the management of these all tumors is very different. The management is based on the biological behavior, whether they are a benign tumor or a malignant tumor, and that is one entity which we need to evaluate on the basis of the history, radiology, and the patient's presentation. We have moved from the time when we just say that something is having a brain tumor, because there is a wide variety of the tumors with the differences in the natural history, differences in their outcome, differences in their treatment protocol. And that's why this is a very comprehensive guideline from 2021 WHO classification of the tumors of the brain, and you will find close to around 600 to 700 different sorts of the brain tumors. That's a huge variety. So I'm not going to burden you with these ones. What I'm going to tell you is that it's not just a pathological diagnosis, because the treatment is very much dependent on the genetic parameter of that tumor, the immunohistochemical parameters of those tumors. That's why once we get a patient of the brain tumor these days, we dissect it layer by layer, going by the pathological diagnosis, immunohistochemical diagnosis, genetic diagnosis, and that composite integrated diagnosis finally decides how is this patient going to behave in the future, and what particular treatment strategy we should evolve, take into consideration for those patients. So once a patient is diagnosed with brain tumor, when I sit in the OPD, it's a very overwhelming moment, because the family thinks that this person is going to die. The patient is very anxious, suffering inside in his own body. We first have to go through a proper, thorough history. Many times there are masqueraders. Patient might be suffering from the tuberculosis. On a scan, it looks likely to be a tumor, but patient is suffering from a disease which can be simply treated with an anti-tubercular drug. So the history remains the cornerstone of your treatment. Then comes the role of the neurological examination. In this era when the residents, consultants, everybody actually just rushes to have a look on the CT and MRI and to conclude for a diagnosis, I would like to reinstate that the neurological examination and the history taking is the cornerstone of the neurological management and the management of these brain tumors. So do a thorough examination of these patients. You would be surprised many times. Even today, I get surprised. The first thing which we get after the neurological examination to confirm our findings, we get a CT scan. Then we need an MRI to look at the particular characteristics so that on pathologically, on the radiologically, we can come to a diagnosis and final confirmation of the tumor. As you all know, MRI brain with the contrast is usually the investigation of choice. There are so many different MR sequences on which a tumor behaves on different parameters. So we can differentiate the appearance of the MRI. And with that, we can differentiate them from the inflammatory conditions, infections, benign and the malignant. And many a times, we are still not sure. Then we have to go with the biopsy. That biopsy might be a minimally invasive biopsy, or it might be an excisional biopsy, CT scans, contrast CT scans, and the MRI of the brain. And with that, we try to evaluate the tumor of origin, the tumor location, whether it's directly from the brain or from somewhere else, and whether it's a benign or a malignant entity. As I told about the various tumor types, the most common ones are the astrocytic tumors, which we call glioma, or the ependymomas, and then various tumors arising from the cranial nerves and spinal nerves, tumors of the meninges, pituitary. So that is actually a more of a concern for a neurosurgeon or for a general physician or a gatekeeper. They should be just aware of that it might be from some or the other part of the brain, but the symptomatology takes you to there. Brain tumors are broadly categorized into the benign and the malignant. What is a benign brain tumor? Benign brain tumors are someone which are lacking the cancerous cells. So they can be removed through surgery and have a low chance of reappearing. They have a slow growth potential. They do not suddenly increase in size. They do not metastasize to other part of the body. And their symptomatology is actually dependent on their neighborhood. So if something is in their neighborhood and they compress over it, you may have a problem with that. Like many times patients come with the skull-based tumor. They do not know that they are having a skull-based tumor, but they are having a pain on the face because the tumor is irritating the trigeminal nerve. And that's how we come to the diagnosis that this particular patient is suffering primarily from this particular brain tumor. And these benign tumors do not invade into the surrounding areas. That's why their removal is easy. In contrast to the benign tumors of any other part of the body, benign brain tumors can occasionally pose a life-threatening risk. The reason is that the brain is a closed compartment. And if a benign tumor increases the intracranial pressure, and the patient may succumb to it. Very rarely, a benign brain tumor in a long course of time can transform into a malignant one, and then it becomes difficult to treat and to control and to preserve that patient's life. The malignant brain tumors are more severe, the gliomas, metastasis, and they have a high growth potential. They can to any other part of the body like the spinal cord. And in those cases, treating them early, diagnosing them early and quickly is actually the key to the success. That is the main point, because these patients have a very rapid natural history of these tumors, and this becomes against a race against the time. If we go with the surgery, we surgeons make a classification with the tumor inside the brain. Hello?
Can you please keep yourself muted? Meena, please keep yourself muted. Okay.
So if you look at the management of the brain tumors, which is actually the second part of my talk, when you treat a patient with a brain tumor, you look at the patient in a holistic way about the age, the possible benign or the malignant pathology. Life is, if some patient with an 80 years old comes with a small meningioma sitting somewhere in the brain, and it's an incidental diagnosis, and that tumor has a very slow growth potential, these patients can be just observed. There is no need for any surgery or intervention. Just a mere diagnosis of a tumor doesn't need a removal, because that tumor is probably not going to create a trouble to those patients. But if the patient is young, they have a very long projected life in front of them, then surgery, radiation therapy, and the targeted therapies become an option in those patients, and they should be considered. The most important thing which I tell my resident is that you should know the disease like a human being. You must know the natural history of the disease. What do you mean by natural history? Natural history means if you do not do anything to this patient, how can this disease affect this particular person? And the natural history can be a very indolent, very benign to an extremely malignant one. So you should be aware of that particular disease and its particular natural history, and then you should take the decision in light of the natural history of that particular disease. Until you know the natural history, as a clinician, I cannot justify my role in the patient's treatment. I may overtreat someone or I may undertreat someone. So always learn about the disease and then you try to treat them, because you do not need to jump over with your knife for every tumor which you diagnose. Many times in my busy practice, I find that patients are being sent to me thinking they are a brain tumor. Like this patient from Bihar, he was presented as a case of a schwannoma of the fifth nerve. But when I took the history and I look at the patient, I think you can see that there is a characteristic reddish discoloration over the patient's face. And then they sent me this MRI, which is showing a tumor sitting exactly over the trigeminal nerve. But the way patient presented, I was not very happy with the natural history and the diagnosis. So what did I do? I took a sample from the patient's face, and it turned out to be leprosy. And then just giving the mere Dapsone took care of this patient, the tumor disappeared, and the patient is completely well now. So you do not need to jump every time. But many times the tumor is voluminous, you are certain that this is a tumor. In those cases, surgery remains the first and the best approach, because if you can remove the tumor completely, the patient gets an immediate relief, immediate decompression of the symptoms, and you get a pathological evidence of the tumor, which helps in the future management of these patients. But once we go to the surgery, we go to the theater. Our aim is to make a meaningful change in the patient's life. And we go with the principle of do no harm. Means we should be able to take the patient in a better situation from the OT than the situation in which the patient is entering into the OT. If I'm able to do that, I am justified as a surgeon, and we evaluate ourselves and our patients on that particular line. What is your aim? For many diseases, tumor eradication is your aim. And for many diseases, tumor stabilization is your aim. So For some benign disorders, many times, if the tumor is adherent to some important structures where removing the complete tumor may jeopardize the patient's quality of life, we leave that tumor over there and we treat them with certain other treatment modalities like gamma knife radiosurgery or some chemotherapies. And we shy away in removing the complete tumor because removing in that way, it doesn't bring glory to us. That bring some important deficits to those patients. So be certain what is the definition of accepted complication and whether your definition of accepted complication is in sync with the patient's definition. Only then you should go with the complete and extensive removal of those ones. Because there has been a paradigm shift in last 5 decades in the management of these brain tumors. For certain disorders, we never operate. We are certain about the diagnosis on the radiology and we treat them straight away with the radiation therapy. Many times, surgery is must. And many times we treat them with chemotherapy because we are sure that the chemotherapy is going to make a better change in the patient's life in comparison to the surgery. Many times I have a leftover. It bruises my ego as a surgeon. But do I really have a residue that needs to be certain? Should I be worried about it? Many times it might be just a benign entity which is not going to increase. So I can just keep the patient under observation. Should I remove it again? Yes, I can go with it. But if the surgical complications are going to be high, then I go with the other treatment modalities. So you should be certain what you're choosing for that particular patient because your technique is going to make a change in the patient's future quality of life. There are other treatment options for these leftover like chemotherapies, immunotherapies. There are targeted therapies which are decided on the immunohistochemical profile. Many times these therapies have to go with a combination therapy, sometimes as a concurrent therapies, and the science is evolving over it. And we are getting more and more targeted therapies, which are very effective for majority of these brain tumors. The radiosurgery, which I also do along with my surgery, is a very different way of thinking. It's a primarily no-sear. It's a radiation tool which is used with the neurosurgical precision. So we are treating so many of these patients without any surgical intervention as an early preventive treatment. Now, as I told you, a person comes with a hearing deficit and we find a small tumor. This tumor is just causing a hearing defect. If I leave it just such, in the next 6 or 7 years, this tumor may increase in size and may become a surgical candidate. But if I treat it with the radiosurgery, means a very focused radiation to that particular tumor, that patient would be having a good period of life without tumor growth and without any further need of any additional treatment. So with radiosurgery, we plan in progression-free survival, better overall survival while maintaining the quality of life and giving a good safety margin. Radiosurgery by definition is administration through the intact skull of the unique and high dose of the ionizing radiation. The skin is going to be burned, the hair would be removed, it would be charred, and the patient would have neurocognitive outcomes. With these sort of the techniques, which are the state of the art and the tumor would be controlled for the rest of your life. These are the radiation techniques which we used to practice some 4 or 5 decades earlier, in which the brain was being fried by the radiation, but that's not the case. Very highly focused radiation like a surgical strike and preserving your rest of the normal brain parenchyma as a daycare procedure in an hour or so, and there is no further need of any other treatment. Like if I show this tumor as an example, somebody tried to operate on it outside and it led to close to around 4 liters of the blood loss. And we treated it directly with the radiosurgery and the tumor disappeared. The surgery has no role anymore and you can treat it with the radiosurgery. This is another example, and you can look at the tumor response over the next 6 months and the improvement in the patient's ocular paresis. So with which particular tool you need to treat, that would be decided on your radiosurgical skills. And a very important point to remember is that many times not doing anything to these patients because they are so advanced disease in its nature course that to do something is probably going to bring more harm. So let the patient just have a palliative care so that they can enjoy the rest of their lives in the care, in the company of their loved ones. That remains a very valid option because many times the disease is advanced so much that doing anything is not going to bring any benefit to them. So the take-home message is that early detection improves the outcome. And the gatekeepers, the people who are sitting at the PSC, CSC, the people who are ENT clinics and the neurological clinics, they are actually have a huge responsibility. So they should diagnose these patients early, or they should at least suspect them and then send them to a particular consultant who are looking after that particular disease, which are usually the neurosurgeons. And as a person sitting in the general public practice, it becomes our responsibility to teach and to increase the awareness about these different treatment modalities. And I am sincerely thankful to SIPHER and Professor Gupta for giving me this opportunity. At PGI, which is actually receiving a catchment of 7 states nearby, we treat close to around 1,000 patients per year with gamma knife surgery people about increasing the general public awareness about their particular disease, and different treatment modalities may help in them. So we make patient information booklets, podcast, and the YouTube channels for them. So whenever you have any query, you suspect anything, you should refer those patients to those particular centers who can take care of this one. Thank you so much for this wonderful opportunity.
Thank you, Dr. Manjul, for a wonderful talk. It was very informative, and you have told us in very simple words. So thanks a lot. And he told that why detection of brain tumor is important. And we are still not able to transplant the brain. All other organs, most of the organs, we have been able to transplant, but not the brain. And the incidence is about 5 to 10 per lakh as per ICMR. So that is also important. And it is going to double in 2040. And the mortality, if I am wrong, please correct me. Is it the mortality is 25% or 35%?
Sir, the projected mortality is 35%.
35%
of these patients who would be diagnosed in 2040.
Okay, and the elderly and the young, they are the high-risk patients. And there are many myths about the brain tumor, that all brain tumors are cancerous. And regarding the mobile phones causing brain tumor, and every headache that is leading to the diagnosis of the brain tumor. And it is not hereditary. And do they come back? So that is also myth. So, and genetic, and there are some brain tumors are genetic also. And they may reappear. The genetic ones, they may reappear. And what causes brain tumor? The radiation exposure, environmental factors, immunological disorders. So he told us so many things that if anyone has a query, they can unmute themselves, or I can ask questions on their behalf. So Dr. Shriram, he said that the best strategy to screen in poor resource settings, like in our sub-centers or primary health centers.
Sir, if I go with if you suspect something on the clinical history and on neurological examination, then CT scans are easily available in most of these places. The availability of the MRI is still questionable. So the CT scan, looking at the CT scan, you can find if there is some edema in the brain, certain part of the brains, because the CT scan is a good screening. So whenever you suspect that one, first you can get a CT scan. It's an easily done procedure. It's half a minute procedure and it's easily available. That's a good screening one. And if you find something, then you should send it to the specialist, because in those conditions, MRI with the particular sequences would be needed. And overall, I would re-emphasize that the neurological examinations, they are the most important ones, not the investigations. The first thing is to just observe, listen to your patient. Do not be in hurry in listening to and coming to a conclusion. So that remains the most important part. That screens your majority of the patients. If you still find that there is something which needs to be investigated, get a CT scan, and you will get the answer in most of these positions. The CT scans and the imaging modalities are to reconfirm your diagnosis, not to make a diagnosis.
So, Dr. Manjul, actually, Dr. Harman Sobti was to join us in this important commemoration, you can call it, not celebration, commemoration of the this brain tumor day. So he's not been able to join, actually. He's trying to join, so maybe join later. If you want to add something, you can just add about the management, about the diagnosis and the management.
Yeah, sure, sir. So I think I do not prepare any slides for that particular thing, but we can just have a discussion about it.
Yeah.
So as we sit in the OPD, and I usually get the referral patients, the patients who are actually being seen by somebody else, and they have a diagnosis in their hand because they usually come with the CTs and MRIs. So they come with their own confusions, their half-cooked knowledge from the internet. They read the MRI film, read the MRI report, and then they search the Google. That happens usually here. So I always give them a chance to tell them what do they exactly know about their disease. And that that becomes a very interesting question, because many times the disease is completely benign, but they have been misguided by the internet and on chatbots. So they become really frightened, and they are skeptical. The family is shivering with the fear that we are going to lose that loved one. So to first know what do they know about their disease, and then to discuss the exact position of the disease in their perspective, that becomes very important. So I give a proper time for around close to around 10 to 15 minutes to understand their psyche. Sometimes, many times, the fear of the tumor kills them rather than the disease itself. Many times they do not need anything. With this sitting in Chandigarh, getting so many patients of benign tumors and they are still very frightened with it, they do not need any treatment at all. Many times they can be treated without surgery and mere observation. That becomes very important with those ones. So having a diagnosis that somebody is having a brain tumor, you shouldn't be that much frightened. There are ways when it can be treated without surgery. I think Dr. Harman just joined.
He has
I'm able
just
to
joined.
see him. Hi, Harman.
So can we call Dr. Harman Sobti? And then you can continue after that. So Dr.
Yeah,
Harman,
sure.
uh, I'll make you a co-host and you can share your slides. So you have been made the co-host. So
Hello?
can you share slides, please? Yeah.
I don't have any slides to show. I'll just
Okay.
let you know with the just a verbal talk.
Okay. So Dr. Harman Sobti, he's a neurosurgeon of international repute, and he is presently in the Sobti Neuro Center in Ludhiana. So over to you, Dr. Sobti.
Yeah,
So he's a
basically,
micro neurosurgeon and neuroendoscopy. He is a master in that, and he's a senior neurosurgeon and a spine surgeon. And current role is as a senior consultant at Mohanbhai Oswal Hospital, Sherpur, and is director at Sobti Neuro and Superspeciality Hospital. So thank you, Yushi, for sharing.
yeah, I would just like to inform that basically what a brain tumor is. A brain tumor is basically just a mass or a growth of some abnormal cells within the brain.
Dr. Haman, actually, Dr. Manjul has told us all about. You can just concentrate on the management part, the diagnosis and the management part.
Okay, so everything has been discussed. Sorry, I got late. I just
No,
happened to
no,
join right
yeah,
now.
you can
So,
just continue telling us about the management part.
so the symptomatology and everything has been discussed. I would like to.
Yeah, it has been discussed.
So management on basically the management is depends upon the site of location of the tumor, the size of the tumor. If the size like is less than 2 centimeters, then very well Dr. Manjul can take care of it with radio surgery and all that stuff. And while if the size is more than that, then we need to intervene with a surgical intervention. It may be a benign tumor, it may be a malignant tumor, whatever the histopathology is that we come to know later. But first of all, the basic treatment is surgery plus radiosurgery and chemosurgery as required, depending upon what type of tumor comes out on histopathology.
Yeah.
So in surgeries nowadays, the surgery is very advanced. It is not that a patient who has come with a problem and after that the problem is gonna worsen. Rather, it is reversed. The problem of the patient improves. The patients improve after surgery.
Yeah.
Like recently, I'll tell you, day before yesterday and yesterday, I've operated 2 brain tumors. Nowadays,
Yeah.
the patients improve after the surgery. Like a patient with a hemiparesis, like hemiparesis, you all understand, that means weakness of one side of the body. So if a patient comes with weakness of one side of the body, we have adjuncts with us. Like we have the neuro navigation. It's just like the navigation we have in our mobiles. So whenever you used to one needs to navigate a place in a city, what we do, we put in a navigation place and we go to that place. Similar is the neuro navigation. We use the neuro navigation in deep-seated tumors. In tumors where we need to have a good access and we need to have this surrounding structures which are very viable, and we don't need them to get destroyed by our surgery or any other maneuver. So by neuronavigation, we directly hit the tumor at the place and we take out the tumor. We come to know how much tumor has been removed, how much part has been left, and the results become way better. With the neuronavigation, we are guided upon the exact location of the tumor, the amount that has been removed, and the eloquent areas of the brain that are very much preserved after the surgery. So the results nowadays have improved a lot with the neuronavigation, with the microscope, and the advanced imaging techniques like the MR tractography. With that, we need where the tracts are going. We come to know which tracts are involved, which tracts are left. So in that ways, we are able to preserve the viable structures of the brain, the loquent areas of the brain, the speech area, the motor area, the vision area, the memory area, all that areas are very much preserved with the use of these adjuncts in neurosurgery, which have now come in help to us. So, friends, a patient who has a brain tumor is not a gone case. It is a very much viable case. A patient can have a good life provided the tumor is not malignant. Yes, if it comes out to be a malignant tumor, then the patient has to undergo a radiotherapy after that, chemotherapy after that. That are the adjuncts which need the patient has to undergo after the surgery. But if it is a benign tumor like a meningioma, once the tumor is out, they do not come after long periods of time if it's a grade 1 or a grade 2 meningioma. However, if a grade 3 or 4 meningioma happens to be, then obviously the patient will require the radiosurgery and the chemosurgery. While if a tumor is a small size tumor, less than 2 centimeter tumor, that can be taken up without surgery, that can be taken up only with radiosurgery, which I'm sure Dr. Manjul must have told you about that.
Yeah.
In that, we need to open the brain. We just need radiosurgery to take up, and the patient, by that, the patient does not require any surgery. Another is the endoscopic brain surgery, which we do in lesions which are of pituitary and skull-based tumors. So in that tumors, we need not even open the brain. We don't go by opening the brain inside the brain. We go through the nasal cavity and the sinuses. Through them, we happen to enter into the brain, and with that endoscope, we are able to take out major of the tumors, like the pituitary tumor of the brain, the skull-based various tumors that are taken up with that endoscopic brain surgery. So, friends, brain tumor surgery is very much advanced nowadays, and the results are very, very good. So, if there happens to be any case, you can always take our help in that case. Any questions from the audience are most welcome.
Yeah, thank you, Dr. Sobti. And we told us about the neuroimaging and then the advanced methods of diagnosis, the radiosurgery, conventional surgery, endoscopic surgery. So we have a question from a participant from Iraq, actually. So do mobile phone and internet towers, they cause cancers and tumors if they are inside residential towers, in the residential areas? So Dr. Manjul and Dr. Harman both can answer these questions. This question.
Harman, would you like to answer it or should I answer it?
Manjul, go ahead.
Both will
No
answer.
problem.
Both will answer.
Okay. That's a very interesting question. I keep checking the literature, I keep checking myself, and I remain skeptical about it. You know, there is something which is called economics, and the economics drives the science. So, as I told you, I repeatedly go through the history of the cigarette smoking. During the time of the Second World War, the whole of the Europe was having cigarette smoking as a culture, especially the people who are going into the troops. And it was confirmed by these various studies, which were actually the sponsored studies in those times, that the cigarette is not a hazard to the human being. So it became a very common practice. Male, female, practically everybody used to smoke. But once the World War II was over and the people of that generation became 60s or 70s, there was a sudden surge of the patients who were having the lung cancers. And then in the retrospect, we could know that cigarette smoke and the nicotine had some carcinogen effect. Now, taking this corollary, that analogy to the mobile now, so far, whatever the studies have happened, they could not have a confirmed causative relationship with the brain tumors. Whether you use the Bluetooth or you have the mobile at your head, or you have the Wi-Fi in your head, because these electromagnetic radiations, they are in your surrounding. There is no level of evidence which can have a causative association of any sort of these ultrasonic radiations to the brain tumors. But the literature is still evolving, and I think we would be better aware of these things down the line 3 or 4 decades. Because these mobile towers and everything, they came in the early 2000 in the world. So that these sorts of low dose radiations, they have a latency period of close to around 3 or 4 decades to create any tumors. So if there would be any tumors, we would be able to know after next 3 or 4 decades. Sometimes if there is any causative effect and the companies come to know that there is a causative effect, they kill those studies. So you need to be really aware what you are reading. You need to read in between the lines, and even the scientific publication, you need to be really skeptical about it. How were those studies done? And were the studies were sponsored by somebody or not? Many times the studies are sponsored and they give you the skewed results. So you cannot actually trust the published literature every time. So this question is fluidic. The answer is still not known, and we are evolving with this particular concept.
Thank you, Dr. Manjul. So, Dr. Harman, you want to add to the answer?
Well, Dr. Manjul has already told in detail that still now, till today, well, there are no such studies which have really proven it that these radiation will will be the cause of any tumor in the brain. But let's wait for a period of time and let more studies come in. Then only we'll be able to come to a conclusion as to what effect they have in becoming carcinogenic. Till today, as there is no study, we cannot say that yes, they are a cause of tumor in the brain.
So,
So
Dr.
Uh,
let's wait.
Harman, the cipher is into tobacco control. We are into public health, but focus is on tobacco control. So, does tobacco cause brain tumors?
Well,
First, Dr. Harman.
as far as whatever we conclude is based on the studies that we have seen in literature.
Yeah.
And the studies have mostly shown that these tobacco is mainly the cause of bronchogenic carcinoma, carcinoma of the chest, and that may metastasize into the brain. But as such, directly tobacco causing effect and having any carcinogenic effect in the brain is not yet to be seen. That we need further more studies, more time, but till today we haven't seen one or where we've seen that a patient who has come to us or there has been any study where the tumor inside the brain has been because of the carcinogenic effect of tobacco. Yes, the chest tumor, the carcinoma of the chest cavity, that can definitely go into the brain. So indirect effect, you can say it definitely has, but directly having having a tumor inside the brain due to tobacco is not yet seen. That is not good.
So,
So
Dr. Manjul, so have you come across
I
any
agree.
such?
I'm actually in sync with Harman's opinion, Dr. Harman's opinion. India is actually the worldwide hub for oral cancers, pharyngeal cancers, and the lung cancer. And the causative effect most of the times is nicotine and its carcinogenic substance. So they make a primary and they get a secondary in the brain, as Dr. Harman rightly told.
Yeah. So there's a question from Dr. Gurpreet Kaur Maan regarding preventive measures. Though you have already told about it, can you just briefly tell us about the preventive measures? Yes, Dr.
So,
Manjul?
sir, for prevention, there are certain family groups which are at high risk for the brain tumors. And we come to know once we discuss it in the family and other family members, if there was someone who has suffered from brain tumors, like the neurofibromatosis, there is Leaf-Romany syndrome. So those patients have come at a high risk, but the number of those patients is still very less. And most of the brain tumors are the sporadic. So there's no point in screening the whole of the population. That is not going to give you any benefit. As far as prevention is concerned, we couldn't identify a majority of the causative factors. In certain points, exposure to the radiation, which is actually a very important one. So the radiation should be avoided as far as possible. As I told earlier, even a mere X-ray or CT scan that unnecessarily exposed. The pregnant females, they should avoid any sort of radiation exposure to the uterus, especially in the first trimester of their life. Try to avoid preservatives in your food. Those are coming up with a big role in tumors of the various part of the body,
Yeah, I think
and
that is
probably we
important.
will find something in the brain as well. And I urge everyone to maintain a healthy lifestyle, do some yoga, give some rest to your brain. In this digital era, we have stopped giving rest to our brain. We are always busy fidgeting with our devices at one or the other time. So give some rest to your brain. That would definitely help. These are the preventive
Thanks.
reasons which I can tell right now.
Dr. Harman, so what is your take on this?
Sorry, what was the question? I got
So
little
it
bit.
was regarding the preventive measures for avoiding having this brain tumor.
Yeah, look, brain tumor is not like the tumors of other part of the body, so there is not much that you can do. All that has come, the brain tumor has, which the patient is suffering, is mainly because of his or her genetics. That is one part which is there, which obviously nobody can change.
Yeah.
Left that aside, the other things which one can avoid is obviously like this smoking, tobacco, which one should, and radiation, which is one thing that the patient should avoid going under radiation, especially youngsters and patient with young age group, if they are exposed to a lot of radiation and with some period of over a time span, they happen to develop tumors. So these are some things which one should avoid. Apart from that, for brain tumors prevention, I tell you, friends, nothing much can be done. You cannot say that this patient will have brain tumor and this patient will not have brain tumor. We have seen patients who have had a very healthy lifestyle, a very good lifestyle, have had problems, and others who have a very bad lifestyle, nothing has been done. So I don't say you should have a bad lifestyle. You should have a good lifestyle. You should yoga every day, exercise every day, eat healthy food, balanced food. That will help in your overall development. A
Yeah.
healthy body has a healthy mind, my dear friends. It is not like with a healthy body you can prevent a brain tumor. But yes, God forbid, even if it comes, a healthy body will be able to fight it much better way rather than a diseased body. A patient having diabetes, hypertension, obesity will have a lot of problems facing a brain tumor, while a healthy body will come out of it within a period of some days. So a healthy body is one thing which will always help you. As regards to prevention, you can say you cannot do anything if you have had it. Genetics you cannot change. Have a healthy lifestyle. That is all I would say.
So thank you,
Very well
Dr.
said.
Harman. So if there are any questions, you can just unmute yourself. And in the meantime, I'll call Dr. Siddhi Hathiwala, who is a public health who is interested in public health. So and she's into tobacco control with us. So can you just summarize the what has been said about brain tumors by Dr. Manjul and Dr. Harman? Dr. Siddhi, are you with us? Dr. Siddhi? Or anyone can unmute yourself and just ask question if there are any. Yes, Dr. Siddhi? Okay, if there are not, oh, Dr. Siddhi Atifala says that she can't speak because she may be in a class. It's okay. So I think we can, thanks a lot, Dr. Harman and Dr. Manju. And she says that she wants to know about robotic surgery. So robotic surgery is I think is a big subject in itself. And Dr. Manjul, we can have him with us for another webinar.
Sure, sir.
So over to Dr. Ayushi, Mr. Ayushi. So if she can just proceed with the formal vote of thanks. Yes, Ayushi.
Sure, sir.
Yeah.
Okay. So thank you to all our speakers for their impactful insight. And on behalf of the organizing team, I would like to extend my sincere gratitude to each and every one of you who participated in today's event. A special thanks to our guests, speakers, and every participant. Your contributions were invaluable. Whether you shared your knowledge, lent your support behind the scenes, or simply joined us with a positive spirit, you made a difference. We deeply appreciate your time and effort, and we hope to see you again at our future events. Thank you once again, and have a wonderful day ahead.
So thank you.
Thank you so much, sir.
Ayushi.
Thank you, everyone.
And we had
Thank you.
some international participants also. So thanks to all of them. And thanks to you, especially Dr. Manjul and Dr. Harman. So thank you. Bye.
Thank you.
Thank you so much.